Aloha, everyone. Welcome to Queen's Free Speaking of Health lecture series. Tonight's lecture is titled Depression in Children and Adolescents. My name is Mina Sugimoto from the Corporate Communications Department here at the Queen's Health Systems. Our presenters this evening are Dr. Angela King and Forrest Wells. Dr. King was born and raised in Hawaii, and after spending 8 years away for college and work and post-baccalaureate classes, she returned to complete her medical school education and training at the University of Hawaii John A. Burns School of Medicine. She then attended UC Irvine for her general psychiatry residency and returned to the University of Hawaii to complete her child and adolescent psychiatry fellowship. She is board certified in both adult and child adolescent psychiatry through the American Board of Psychiatry and Neurology. She is currently the child and adolescent psychiatrist and clinical supervisor at the Queen's Youth Partial Hospitalization Program and also has her own practice. Forrest Wells is a licensed mental health counselor in Hawaii and works as a clinical therapist, clinical supervisor, and program coordinator for the adolescent outpatient behavioral health programs at the Queen's Medical Center's Day Treatment Services. Forrest is a nationally certified counselor by the National Board of Certified Counselors. He has 10 years of experience working in services contracted by the Hawaii Department of Education and has been a licensed mental health professional since 2011. Forrest also maintains his status as an adjunct professor at Hawaii Pacific University's Master of Arts in Clinical Mental Health Counseling program. Please give a very warm welcome to Dr. Angela King and Forrest Wells.
So first off, thank you guys for all coming out tonight. I know that this is a very relevant topic within the community right now. And in the overarching topic of mental health, depression is a significant piece that contributes to mental health conditions and possibly a lot of the symptoms that we see generally in the community. So we want to just provide, Dr. King and I want to provide this as information. It's not meant for you to be able to leave this tonight and provide diagnoses for any of your family members. It's not meant that you'll be able to go home or leave here tonight and be able to engage in interventions and therapy yourselves. But we want you to know what to look out for, what to see when you suspect somebody is struggling with depression, and then what therapy will look like if they start to engage in therapy and seek help for their depression. So Dr. King will start us off with a review of depression, diagnoses, and the emotion.
Hi, welcome. Thank you so much for making it out. Like Forrest was saying, mental health is an important area for us to talk about, and so we're glad that you are spending this evening with us to learn more. So we're talking about depression in children and adolescents. Just briefly going through the definition of depression. If you look in the dictionary, the actual definition would be as the emotion of depression, an act of depressing or a state of being depressed, such as a state of feeling sad, dejection, anger, anxiety, and depression, or in biology, a lowering of physical or mental vitality or a functional activity. And then if we look at the specific criteria for major depressive disorder, we want to start with one of the other diagnoses, adjustment disorder, because sometimes it's not something that lasts for a long period of time. It's something that's situational. So going over adjustment disorder, the development of emotional or behavioral symptoms in response to an identifiable stressor occurring within 3 months of the onset of the stressors. The symptoms or behaviors are clinically significant as evidenced by one or both of the following. So marked distress that is out of proportion to the severity or intensity of the stressor, and significant impairment in social, occupational, or other important areas of functioning. And the stress-related disturbance does not meet the criteria for other mental health disorders. The symptoms do not represent normal bereavement, And then once the stressor has terminated, the symptoms do not persist for more than an additional 6 months. So we can see with adjustment disorder, it's a diagnosis that we can see when there's a situational stressor. So the expectation is that once the stressor or the situation is done, that the symptoms will not last more than 6 months. And then there's modifiers that go with adjustment disorder. So the one that would be similar to major depressive disorder is with depressed mood. So the types of symptoms you would see with that is low mood, tearfulness, or feelings of hopelessness being predominant. The other modifiers that you can see with adjustment disorder are things like with anxiety and depressed mood. Other categories include with disturbance of conduct or with mixed disturbance of emotions and conduct. So again, even when you have these symptoms with adjustment disorder, the expectation is that once the situational stressor is over, then these symptoms will also resolve. So now going on to major depressive disorder, the actual DSM-5 criteria. So the DSM is the manual that psychiatrists, psychologists, therapists refer to in order to have the defined criteria that we look at. It's not quite, a black and white, like it has to be all of these. In some situations, we're using our clinical judgment as well. And so this gives us kind of a standard, something to look at so that we have something to base our evaluations on. So for major depressive disorder, there's at least 5 of the following symptoms, and they have to be present during the same 2-week period and represent a change from previous functioning. So that's a part that is important to point out, that it's not only that you have these symptoms, but that it also represents a change from previous functioning. So the things that you want to look at are things like depressed mood, diminished interest or loss of pleasure, significant weight change or appetite disturbance, sleep disturbance, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness, diminished ability to think or concentrate, and recurrent thoughts of death or recurrent suicidal thoughts. The other part that's important to look at is that during the 2-week period, one of the symptoms has to at least be either depressed mood or the diminished interest or loss of pleasure in activities, which we also call anhedonia. And as I said before, again, we want to see if the symptoms cause a significant distress or impairment in social, occupational, or other important areas of functioning. Because there are some adolescents, children, adolescents, and adults that will have these symptoms, and they might come and go, they might last for a day or a week, but eventually they will go away and they may not linger. And so we want to make sure that if we're diagnosing someone with major depressive disorder, that we're actually looking at cases where the symptoms are lasting for at least 2 weeks and it is causing an impairment in their functioning, whether it's at school, at home, relationships. The symptoms are not attributable to the physiological effects of a substance, so that's important to note. And disturbance is not better explained by a persistent schizoaffective disorder, schizophrenia, schizophreniform, delusional disorder, or other mental health diagnosis. And also it's important to note that there's never been a manic episode or a hypomanic episode, because that might signify something different, such as bipolar disorder. So the only exception is that if someone is on substances, they might have something like major depressive disorder and also have a type of hypomanic episode, and that would be an exclusion. So if we're looking at the statistics, it's important to note that pediatric depression often appears in primary care settings, and it's often undertreated. Many times, the first line is going to be the pediatrician, the primary care physician that evaluates the patient, maybe a checkup, a normal well-child visit, and what happens is they usually have now specific screenings that they go through, and they'll find that on these screenings, some of the answers are kind of indicating that someone might have anxiety or someone might have depression. And so what happens is usually they'll refer them to a higher level of care, or they'll refer them to a specialist or a therapist, psychiatrist, someone that can follow up with them in terms of their mental health. There's been multiple studies that have shown that roughly 40% of children and adolescents with depressive disorders are not treated. Also, the ratio of adolescent females to males who develop major depression is approximately 2 to 1. We also see a sex difference emerging in puberty. So it's interesting to note that in adolescence, the risk for developing depression is greater in girls than in boys. But it's also important to note that pre-pubertal children, so depression appears to be more common actually in boys than girls. Moving on with statistics, so these are some of the risk factors for the onset of pediatric depression. Things such as low birth weight, family history of depression and anxiety, family dysfunction, exposure to early adversity, psychosocial stressors. So we often see this in the program that we work in, at the partial program. There are many stressors that the adolescents are going through in terms of school, family, and so many of these stressors are going to be risk factors for the adolescents. Gender dysphoria, negative style of interpreting events, and coping with stress. So there might be, the two adolescents who are going through the same stressors, but one adolescent might be able to deal with it in a positive way in terms of being very resilient, whereas the other might not have the best of coping skills. And so our job is to help them to find healthier coping skills. History of anxiety disorders, substance use disorder, learning disabilities, ADHD, and oppositional defiant disorder. So many of these are comorbid, meaning often you'll see things like an adolescent might have depression, but with that they might also have anxiety. Usually you won't see just one or the other. And so often we'll ask, which came first? Was it your depression that came first? Is that the primary diagnosis? Because many times one will then lead to the other. Traumatic brain injury and chronic illnesses. This graph just shows in terms of the prevalence in pediatric population. So one thing you'll note is, at least with depression and anxiety, there is an increase with age in terms of seeing the prevalence is higher in the 12 to 17-year-olds compared to the younger ages. And one thing also to note is that these aren't exclusive in terms of there is the risk of being comorbid, having comorbidities of depression and anxiety together. So just because someone shows up in the depression graph doesn't mean they're not showing up in the anxiety graph. And they often do come together. And these key points point that out. So in terms of when we look at the comorbidity, we can see that about 3 in 4 children aged 3 to 17 years with depression also have anxiety, and almost 1 in 2 have behavioral problems. Then for children aged 3 to 17 years with anxiety, more than 1 in 3 also have behavioral problems, and about 1 in 3 also have depression. And for children aged 3 to 17 with behavioral problems, more than 1 in 3 have anxiety, and about 1 in 5 have depression. And then the last bullet point, nearly 8 in 10 children aged 3 to 17 years with depression receive treatment. So I did note that that seems like a higher percent in terms of those that are receiving treatment compared to the slide I showed here with the second bullet point that said that multiple studies have shown that roughly 40% do not receive treatment. And that might have something to do with the differences in reporting. So it might be that this resource could have been in more of a primary care setting. And so depending on who's reporting depression or who's actually reporting it, is it the pediatrician, is it the psychiatrist that are reporting, the data? That's where the differences might be coming from. This last bullet point, I think the resource from this one actually is more inclusive because it's coming from the CDC online website. So this is higher, most likely because it's including both the primary care and specialty reporting, specialist reporting. Okay. So going on to other diagnoses related to depression, we can look at the differential diagnosis. So one of them is bipolar disorder. And what differentiates it is that it also includes manic, which at least has to last at least 1 week, or hypomanic episodes, which last at least 4 days, along with the depressive episodes. Another one that we think about is disruptive mood dysregulation disorder. So this actually is classified under depressive disorders when you look at the Diagnostic Statistical Manual. And what differentiates it is it includes severe recurrent temper outbursts manifested verbally and or behaviorally that are out of proportion to the situation. The temper outbursts are inconsistent with the developmental level, and they occur on average 3 to 4 times a week. So often you'll see adolescents that, they're having problems with severe anger outbursts. And this, in some ways, can be kind of a normal, what we see in adolescents. But at the same time, if it's, very often, 3 to 4 times a week, inconsistent with their developmental level, very severe recurrent temper outbursts, that's where we decide maybe it's something more than that. And also the mood between outbursts is persistently irritable or angry. And then another differential we included is the persistent depressive disorder or dysthymia. So what you're looking for there is depressed mood for most of the day, for more days than not, for 2 years. And in children and adolescents, the mood can be irritable and the duration must be at least 1 year. So Forrest is going to transition on to more of the signs and symptoms that you see in adolescents.
Thank you, Dr. King. Please take notes on things that you have questions with. I know that we have a lot of information to get past, so I'm sorry if we kind of glaze over some of the things, but note them down if you want me to come back during the question and answer section. So signs and symptoms. The initial signs are definitely those just related to depression when we talk about depression, the emotion. And that can be loss of motivation, irregular sleep, either sleeping all the time or sleeping very little, irregular eating very little or overeating. So this differentiates from eating in the sense of restrictive eating that could be more indicative of a eating disorder. We're looking at the loss of appetite, or with the overeating or increase in eating or noted increase in eating, it could be what people often call eating your emotions, so emotional eating. Then also not enjoying activities that were previously enjoyed, expressing sadness just in general, excessive worry, self-blame, guilt, regret, shame. Hopelessness is identified as a feeling of not having any other outlets, not having any other answers aside from not being able to help yourself, or also when we go down to the bottom, feeling that death or suicide would be the only answer to solve a problem. And then when we get to helplessness, helplessness is similar to hopelessness, but it differs in the sense that they don't feel that they can do things on their own, that they need the constant help from other people, and they are dependent on others. And then we get to self-harm, which tends to be a distraction from the emotion. It also releases a lot of the chemicals within your brain that address sadness in general, but that becomes a very difficult maladaptive coping mechanism. So where somebody, it is actually coping with the depression at the time because it draws attention away from it, but over time, the self-harm increases because the same self-harm no longer is as effective. And it can cause many other problems such as infection, scars, and some social isolation as well. And of course, when we get to thoughts, suicidal thoughts or statements, and then frequent thoughts of death or dying. So somebody talking about being dead, what it would be like to be dead, or if problems are solved by death. Then we get into behavioral problems. Just as Dr. King had said, a lot of this is comorbid or overlaps with depression. So persistent or angry or irritated mood, they quickly get angry or irritated, overreactions of anger, which are primarily described as a response of anger that does not match the action, such as, say, a parent puts a child's socks in the wrong drawer, and they begin yelling, swearing, throwing things around their room. That would be a pretty good indication that something else is happening underneath that anger. And anger in general is a secondary emotion. So it is driven mostly by fear or depression. And it's a defense mechanism to engage in a control taking of a situation instead of feeling helpless to the emotion of depression or fear. The physically acting out, I think I kind of covered that. The defiance, not listening, being resistant to patient or parent direction or school direction or other authority. Substance use, often to kind of just blank out the mood of depression. The clinginess we see in younger children, but it can also be in adolescents and teenagers where they revert back to wanting to be around a certain parent or family member more so because they feel that helplessness, that they need that person to help them with their mood and with other day-to-day functioning activities. And then school avoidance or refusal. And this attaches to many different things, primarily self-esteem, feeling like they don't fit in or don't belong. And those are all very indicative of a depressed mood. And then isolation. So a significant reduction in social activities. So in the home, they're no longer out of their room as much. They no longer do things with friends. They no longer go out in the community or participate in sports activities or other clubs that they may have participated in previously. They have a shrinking friend group. They no longer hang out with the same or as many people as they used to. And then going back to how to see the signs in children and adolescents. A lot of these things that I went over are part of natural development. So sometimes a child will have some moodiness transitioning from being a younger child to an adolescent through puberty. They will also have changes in preferences on activities, changes in friend groups, and it really is based on parents, family members that really know the child to see if it's something that is really out of the ordinary in comparison to how they generally act and how other peers around their age are acting as well. So how to be supportive? Empathetic listening is the best base of support I could come up with for the means of this presentation. And the first part of it is being non-judgmental. If a child or adolescent is coming to you and reporting their mood, to take it as is, to accept that that's how they feel. It's very common for people in general to have that kind of suck it up type of attitude. If somebody's saying, oh, well, you know, I really just feel like I'm sad or nobody likes me, everybody feels that way sometimes. You know, you'll get over it, it's fine. And what that does is it invalidates their feelings, for one. It makes them feel like they're wrong, or you may think less of them if they continue to talk about it or persist with that problem. And it keeps them from coming back for help. So maintaining that non-judgmental response is really helpful in continuing to support the child or adolescent that's coming to you for help. And give the person your undivided attention. Make them know that you are paying attention to them, that you are listening, that you hear them. And this isn't that you know that you hear them, it's that they know that you hear them. I know that we can all multitask. Being able to do something on your phone while the child is talking to you is a skill of the 21st century. But it does not show that person that you're giving them your undivided attention. So if you have the capability, if you have a child that's coming up to you, a child or adolescent that's coming up to you and expressing their needs, their emotions, put down what you're doing, stop what you're doing. If you're engaged in a task that you can't stop immediately, let them know that you want to hear that and when you can give them your undivided attention. Because that will, again, help foster them coming to you for support. Listening carefully to the feelings and the facts. So you want to listen to the actual things that happened and the feelings behind them. If they're expressing certain facts in a different tone that gives you any inclination that there's some emotion attached to it, that's probably a pretty big piece that you want to follow up with. Show that you're listening carefully. So feed back to them some of the pieces of what they're saying. Let them know, like, okay, I heard this part, you know, and it sounded, as I said, if you hear a tone, you sounded really sad when you said that, you know, what's going on with that? So that they know that you're paying attention, they know that you hear them. And don't be afraid of silence. If you're asking a question and they're not responding, they might need some time. This is often very difficult on both ends. For the person asking the question, you really want to get to the bottom of it, and people are busy, so you sometimes want to get through it quickly. But allow them to sit, think about it, and then be able to let you know how they're feeling. And then restate or paraphrase, like I had said earlier. And follow up later in the night, later in the day, later in the week. Check in. Say, hey, you know, when you talk to me about this, how's everything going? You know, I really wanted to make sure everything's okay. Really wanted to make sure that there's nothing else you need to talk to me about. And just make sure that you come back to it and don't just let it go as a one-time thing. So now we get into the basics about treatment and medication. I rushed through that last part because this one might be a little lengthy. This is the almighty cognitive behavioral therapy triangle. This is the base of most modern-day therapy approaches and theories. So it outlines the interconnected cyclical patterns of thoughts, feelings, and behaviors driven by core beliefs. That's a very clinical sentence. In general, it means that your thoughts influence your feelings Your feelings influence your behaviors, and they're all driven by a belief that you have. And when these patterns happen, they repeat. So being able to identify first the patterns of thinking, feeling, and behaviors that can be fostering depressed mood or maybe a negative core belief, and then making changes. So we'll run through a basic example of this. So this is a situation. Someone forgets to turn in their homework. Very common child-adolescent type of problem. It goes through their core belief. So if they already have a pre-existing notion that they're a failure, that they're not good enough, anything along those lines, forgetting to turn in their homework will go through that and turn into a thought, which is, I'm going to fail this class. And then that thought will translate into a feeling, which could be fear of failure. So this, noticing that they forgot to turn in their homework, going through I'm a failure, turning into the thought I'm going to fail a class, usually happens within a fraction of a second. This is automatic. It's very quick. So in cognitive behavioral therapy, a therapist or a mental health professional will often break it down in this way so that you can outline what's actually happening in those quick transitions from a situation turning into an emotion. Then it turns into a behavior. They act sick to stay home from school. And then that goes back to another thought that I'm falling further behind because now I've stayed home from school as well, which then fosters feelings of hopelessness. I'm not going to be able to do this. There's nothing else I can do. I forgot to turn in my homework. I stayed home from school. Then they start ditching school when parents figure out you're not really sick, you got to go to school. And then they get the thought, I can't go back to school. I've already failed. This is done. And this obviously isn't exactly how every single situation where somebody forgets to turn in their homework goes, but this is a possible scenario. And being able to interchange these patterns of thinking, feeling, and behaviors with other situations that you may see in children in your families, children that you know, can help you have a little bit of a better understanding. And again, this is a base of most therapies. So when we go back and we start the same process over again, process of identifying what's happening, and we get to this point, and somehow somebody has an intervention. And this doesn't have to be a therapist. This can be just a parent, a teacher, somebody else concerned that says something or talks to this student, child, and then it influences the thought, I need help, instead of, I can't go back to school. And then from there, it can promote feelings of hopefulness, that they're like, I need help, there are people available to help me. They start to ask teachers for help. Teachers help them out. They start to think, I can do this. And then that's where the goal of cognitive behavioral therapy in general is to change that core belief from I'm a failure to something more healthy, such as I can do better. Not exactly like I'm the best in the world, because that will be unrealistic and it won't be believable to them. But this base of cognitive behavioral therapy drives most of the therapy that is out there today. Much like it drives dialectical behavioral therapy. So dialectical behavioral therapy is driven off of cognitive behavioral therapy. And the reason I go in depth over these two very heavily, one, because they're the two modalities of therapy that I'm very familiar with, that I utilize very frequently in practice. And they are the most empirically proven to be effective in treating depression, anxiety, personality disorders in children and adolescents. So the 4 parts of dialectical behavioral therapy, and if you're having trouble with the word dialectical, it means having 2 seemingly contradicting thoughts or ideas that are both simultaneously right. So the idea of having 2 perspectives that you feel conflict each other, but acknowledging that they're both right because they're perspectives. And that can be the idea of somebody thinking that this shirt is really nice, or somebody thinking that this shirt is really ugly. Both right in that person's mind. So it's not an if or, it's not this or that, it's and. They are both correct, and being able to be accepting of having 2 conflicting ideas that are both right. And in dialectical behavioral therapy, it dives much deeper into that, but that is the base, and that's where that word comes from. A lot of people have questions on that word particularly. So mindfulness in general, the base of mindfulness is meditation. That is the most commonly seen practice of mindfulness. And mindfulness means being able to control your mind, being able to manage your thoughts and your attention. And everybody has a general idea that they feel, I'm in control of my thoughts, but we often have impulsive thoughts, or we have reactive thoughts that happen without our intention. And mindfulness is being able to use your intention to control your thoughts. It may not stop those impulsive, reactive, or intrusive thoughts from happening, but it can help you identify them and then take control over that and change them to something that could be more helpful. And it focuses very heavily on being in the moment, not focusing on any past regrets, shame, not focusing on any worries about the future, just focusing on the here and now and what's happening here and now. Because typically most fears exist in the future, and most depressed feeling exists in the past. Shame, regret, embarrassment, they very infrequently exist in the present. And then it has distress tolerance, which is exactly what the name sounds like. Being able to develop and tolerate stressful situations. They're based on endurance and remaining calm. This acknowledges that you will not be able to eliminate stress from your life. Stress is a constant, it exists. And the levels of stress that we go through minute to minute, day to day differs. But we will all in this room have a time, probably within the near future, that we experience some significant stress. And the idea of distress tolerance is being able to experience that stress without it becoming too reactive or leading to detrimental behavioral actions. Emotional regulation, also very self-explanatory. Being able to identify how you're feeling in a moment and then taking control of that emotion. Being able to monitor your reactions to emotions and make sure that your emotions aren't driving your behaviors in ways that will have negative consequences. And then interpersonal effectiveness, which is basic communication skills. And the communication skills in being able to identify conflict and reduce or manage conflict between others. The other therapeutic approaches that are worth noting are behavioral therapy, which is a piece of cognitive behavioral therapy. This often exists with behavior modification. Applied behavior analysis uses this very heavily. Cognitive therapy, using in training of restructuring of thoughts. Interpersonal therapy, which, as I discussed, was part of the dialectical behavioral therapy. Problem-solving therapy, which face problems with a very solution-focused viewpoint. Play therapy, which usually requires some training to implement correctly or effectively. Non-directive supportive therapy. can be unstructured therapy without specific psychological techniques, but it helps people to express their experiences. Psychodynamic therapy, which is more of that, I guess, historically portrayed therapy in TV shows and movie, where you're laying on the couch and how was your childhood, and kind of reviewing all of the life events that had led up to actually developing core beliefs that exist now and how to kind of diffuse and restructure those. And it's one of the more long-term therapies instead of some of the short-term, like solution-focused, and cognitive behavioral therapy can also be solution-focused and short-term. And then family therapy, which is generally family therapy that can incorporate these other techniques, such as the cognitive behavioral therapy, the triangle we just went over, would then include different pieces of the family and how they interact together and cause a cycle of behavior as a family that may be detrimental or difficult to manage. And Dr. King will follow up with some of the other approaches.
So going on with treatments, there's the therapy approaches, which Boris went over, and now we're going to talk a little bit about pharmacotherapy. So it is noted that among children and adolescents with depression who receive standard treatment, psychotherapy alone is used most often. The second most frequently used treatment is medication on its own, and then the least used is the combination of psychotherapy and medications. And so in child and adolescent psychiatry, many times when there is a case of moderate or severe depression, that's when we start to look at, are there other treatments other than just therapy? If the therapy is not fully effective on its own, then we will consider adding medications. People have different approaches in terms of treatment, but I would say most psychiatrists, we want to, of course, minimize the number of medications in terms of, especially with children and adolescents. So if things can be treated with just therapy alone, then we don't necessarily have to add the medications. So the studies have shown, though, that being said, I think in mild cases of depression, we often look to therapy. If it's moderate to severe, that's again when I said you might want to add with the therapy medications, because it has been shown that many times with pharmacotherapy and psychotherapy, the combination is going to be more effective. And so in this study, the treatment for adolescents with depression study, they compared fluoxetine plus CBT sessions with placebo, and the response defined as much or very much improved occurred in more patients who received combination therapy than placebo, which you probably would expect. The following two are examples of how studies where combination therapy compared to, in the first one, pharmacotherapy plus CBT compared to pharmacotherapy alone, the combination, although both were comparable in terms of the improvement of depression and the incidence of suicidal thoughts, the functioning was better in patients who received the combination therapy. And the next point, that there also have been studies showing that when you compare medications, SSRIs plus CBT with medications alone, there was a trend for remission to occur in more patients who receive the combination therapy rather than just medications alone. So, those are just some studies that are showing, meta-analysis showing that combination, of medications and therapy often is going to be more effective than either alone. So this next slide goes over the most common antidepressants, which are also often used as first line for anxiety as well. So in the first category, the one that many of you may have heard of are the SSRIs. That's usually the first line. If they haven't been on any medication before, usually we'll recommend an SSRI. and that stands for selective serotonin reuptake inhibitor. So things like, the first name is going to be the generic name, and the name in the parentheses is the brand name. I know it can get confusing because there are a lot of names that are thrown out there. So one point to make is the SSRIs, it's not that they're making or creating more serotonin. When patients are being treated with SSRIs, what it's doing is utilizing the serotonin that's there more effectively. The reason why is because when it's not being reuptaken, so it's happening where in the neurons, in the spaces between the synapses where the neurotransmitters are going from one neuron to another, it's basically allowing the serotonin to stick around a little longer. The other categories are similar but a little different. So SNRIs, so that's including serotonin and norepinephrine. And these are all neurotransmitters that are involved in depression and anxiety, and that's why they tend to help with the symptoms. The third category is norepinephrine and dopamine. So the common one in that is Wellbutrin. And then some of the newer antidepressants that you may or may not have heard of, one of them is vortioxetine. And then that one actually is very similar to the SSRIs, but it's also thought to have additional serotonin properties that make it slightly different from the SSRIs. And then the last category is the adjunctive medications. So for those, especially in child and adolescents, we try not to, immediately go to adding additional medications if we can. Like I said, simpler is always better. If we can stick to one medication, that's always preferred. But sometimes the one is not quite enough, and that's when we look to other medications that we can add. So things like aripiprazole, brexpiprazole, quetiapine. So those are in the category of atypical antipsychotics, but at low doses, they're actually used as adjunctive medications for depression. It's at the higher doses that they're used in diagnoses such as schizophrenia, schizoaffective disorder. There's also ones, that I didn't include, things such as the tricyclic antidepressants, but especially with children and adolescents, we don't tend to go to those. Those are, the older medications, and they tend to have more side effects. So the ones I listed are the most commonly prescribed. Then there's other non-pharmacological alternatives. So you may or may not have heard of transcranial magnetic stimulation. So I'm not an expert in this, but I wanted to list it as an alternative. There are providers on the island that, do have training in this and have this set up in their office. And it's something, to consider, to look into, especially if, the medications are not well tolerated, you're having side effects. Definitely, something that you can do more research into. But the thought basically is that this electromagnetic coil is placed against your scalp, and it delivers the magnetic pulse that stimulates the nerve cells. And then it's thought that that stimulation then can help with mood control and depression. In some ways, it seems like it's a milder version of ECT. It's the thought is that with the stimulation of the brain, that it can somehow kind of help with the brain chemistry. So the other alternative is ECT, and it's electroconvulsive therapy. This, many times it does have a bad rep or stigma to it. Many times it's something that we think of when we see older movies or, but it's good to know that, nowadays there are ways they actually give anticonvulsants when they do the treatment, so it's not what you see in the movies and, how it's portrayed. It's actually done on the same day, as a same-day procedure. They do have providers that are doing this at Queens. It's usually reserved for cases of severe depression or treatment-resistant depression. Again, many times when the medications are not well tolerated, there's many side effects, or they've gone through countless medications. And it's important to note that, at this point, it's usually where you're weighing the risks and benefits of treatment. So yes, there are, possible side effects with ECT. Sometimes there's possibility of a little bit of memory loss around the time of the treatment. And so you have to kind of consider these things, weigh the options. But for someone that is severely depressed and not doing well, and it's affecting every area of their life, or they're not getting out of bed, they're not eating, they're not keeping up with their daily activities of living, then this actually, this might be something that's even life-saving for them. So again, it's done under general anesthesia. It's a small electrical current passed through the brain in a way just, triggering a small seizure. And again, it's thought that this can then cause changes in the brain chemistry that can help with mental health diagnoses. So next, we're going to go over resources for help and information. So in crisis, when you're in crisis, it's important to know the numbers that are available. This is in situations where, especially with adolescents, they often don't want to talk to family, or they don't feel comfortable always talking to people that are closest to them, or even to teachers. Sometimes they don't want to share things with friends. They're embarrassed. They don't know who to turn to. And sometimes things are happening like in the middle of the night, and they don't know who to turn to. And so numbers like this, like the Crisis Line of Hawaii, are helpful because they're available 24/7, and they can contact those phone numbers and find out how to get further help. So there's that number on Oahu, 832-3100, and the toll-free number as well. And then the National Suicide Prevention Lifeline. And then texting, that's, what is most common with adolescents and many adults these days as well. So it's important to note that as well, that there's a crisis text line. And they just have to text CONNECT to 741-741. And then lastly, there's 911 if needed. I think one thing that's important to note is that if you're ever wondering, should I call? Is this a situation that, warrants the call? If you're at all worried about individual safety, either to themselves or to others, it's always better to make the call and, let the professionals at EMS come and evaluate the situation to see whether or not, it has to go to ER or what has to happen. But it's always better to, be cautious and safe, especially when you're dealing with safety concerns, especially with, those that are having thoughts of self-harm, suicidal thoughts of harming others. Typical outpatient resources. So we do have the Queen's Counseling Service. It's in our outpatient psychiatry clinic. It's actually right next to the Zippies on Vineyard. So it's not here at the main hospital site, but it's just down the street. So you are welcome to call them to see if they're available providers for treatment. And also you can reference your insurance provider website, contact them to see which providers are available through your insurance.
Okay, so actually I'm going to back up just a second, just to touch on some of the crisis lines. To call the crisis line or crisis text, those can be situations such as self-harm, not immediately identifying having suicidal thoughts, suicidal ideations, or talking about harming self or others. And this is if it's noted self-harm that isn't ongoing currently and doesn't seem to be an immediate danger It's just that somebody is coping in a not healthy way. And 911, of course, is what you want to call if there is the immediate concern for safety, immediate concern for any suicidal or homicidal ideation. I just wanted to make a little bit of a clarification on that. And that we did not note all the providers for typical outpatient therapy because that is a very large pool of people, and we do not have enough slides to go over all of the providers. But definitely go over, contact your insurance companies, either website, call them, email their helpline or help email, and you can see what providers are available and that your insurance will cover. Going into the intensive outpatient programs, there are 2 different levels of care that we have here locally. And I was able to provide our number as well as the number for Kahi'imohala, and that's because the resources are so limited in this area, especially for depression. There are a little bit more for substance abuse, and there are some also for eating disorder, but specific to depression and general mental health conditions, there's only the 2 of us on island that I know of, and the third-party Department of Health, which kind of helps between those. So with the youth partial hospitalization program, that's primarily where Dr. King and I work, and it is 5 days a week, 6 hours a day, so Monday through Friday, 9 a.m. to 3 p.m., and it's based very heavily on the cognitive behavioral therapy and dialectical behavioral therapy that I went over earlier tonight. And it's group therapy. So 4 to 5 therapeutic groups throughout the day, and as it is 5 days a week, 6 hours a day, that is that the patients are coming to program instead of school. And we'll coordinate with the schools to make sure that academics are covered within whatever means the school can help in providing work that can give a grade for the work, but not the full course load that somebody would be expected to do if they're at school 6 hours a day. And again, this is a higher level of care. This isn't the first therapy option. This is if other avenues of therapy, such as typical outpatient therapy, are not productive, are not helping, or if somebody has gone through an immediate crisis and has gone to the emergency room, had emergency services involved, has had to have a psychiatric stay at the hospital, and is stepping down to this program. We also are reintroducing an intensive outpatient program in the summer, and this is 3 days a week, 3 hours a day. So less intensive than partial hospitalization, but still more intensive than typical outpatient. We had done this before in the evenings, like we had done our partial hospitalization program where we have rolling admission and discharges, but we found that it's a very long day for a child to go to 6 hours of school and then go through 3 hours of therapy at the end of that 3 days a week. So we had a very difficult time with compliance. So we're going to reintroduce this over as a summer program. And if you had grabbed the handout over at the table, we had it out front. You can see what that's about. And you can also contact the day treatment services to get additional information. But it's going to be based on the same concepts of cognitive behavioral therapy and dialectical behavioral therapy. And then we have the Department of Health Child and Adolescent Mental Health Division, which is referenced to usually as the acronym CAMHD. They can provide services of mental health care coordination and individual intensive in-home therapy, functional family therapy, multi-systemic therapy that can meet in families' homes, in the community, help with coordination of services in school. And it's a very comprehensive service, but you would need to have a referral to get those services, and it can be done through outside referral or through school IEP. And then we have Kahi'imohala, which also provides an adolescent partial hospitalization program. And I'm just not very familiar with their program. I know that it's similar to ours, but I'm sure it has some differences that are specific to their program. And then this is the higher level of care, which is inpatient. So we do here at Queens have the Family Treatment Center that is a child and adolescent acute psychiatric hospitalization, meaning that they're being hospitalized due to safety concerns that involve mental health. And this isn't a program or service that you can just call and say, oh, I think my child or my family member should spend a couple days there. This has to be through emergency room admission, where if a child or adolescent goes to the emergency room because they're expressing any concerns of safety, harm to self, harm to others, and a psychiatrist in the emergency room identifies that they don't feel safe with this child returning to the community or home at that time. And it doesn't have to be specifically to suicidal or homicidal thoughts. It can be due to psychosis or other mental health conditions, but for the purpose of this being on depression, that's what I'm going to reference the most. And it would be a relatively short stay. I know they try to stabilize patients as quickly as possible and get them back into the community, and often with a step down to the partial hospitalization program that I talked about earlier. It doesn't mean that they have to go through a partial hospitalization program, but if there are any additional concerns, that will most likely be a recommendation. But if it is a crisis of situation where they just need some time to process it, come to terms, and then feel comfortable returning to the home and having typical outpatient therapy as follow-up, that's also a possibility. And then at Kahimo Hall, they also have the acute psychiatric hospitalization as well as a residential treatment program for adolescents. And this is similar to partial hospitalization in the modality of treatment and how they deliver the therapy. The difference is that the patient stays there as they would with acute hospitalization because they need that additional monitoring for safety in the times between receiving direct therapy. And the timelines on this can be different, typically at least a month, and it can expand out from there. And this is the only on-island option for residential treatment, and there are off-island options as well. But it is typical to utilize the on-island or in-state options first to make sure that they don't have to be more intensive or be more restrictive to where somebody's not on the same island as the rest of their family. And unless Dr. King has anything else to add, I think we can move on to our question and answer segment.
That was excellent information, right? Yay. So we have our volunteers, Jen and Sophia, with microphones, and raise your hand if you have any questions for either of our experts. Anybody?
Hi, thank you for that. I just wanted to ask a question about the empathetic listening.
Mm-hmm.
Can you give some examples? I think as parents, you want to hear your child and you want to give them encouragement or let them know you're listening. But like the example that you mentioned of, well, you know, a lot of people feel like that at some point or another, or everybody feels like that. I'm not trying to be dismissive or minimize it, but can you give examples of giving them some sort of empathetic listening or some feedback rather than, you know, I think as parents, we also try to help them solve something or give them encouragement, like, oh, maybe, you know, your friend didn't mean it that way or something like that. How do you?
No, I definitely understand it. That's one of the reasons I wanted to touch on the empathetic listening. I'm sorry that it was a brief presentation, so we couldn't dive too much into it. But in general, sometimes not providing a solution, being able to say, wow, that sounds really difficult, being able to identify some relatability to, you know, I've had some friends that did this as well, and I really felt bad. I was really self-conscious about myself, building some relatability, and then even asking like, well, do you want some advice, or do you just want to kind of vent it out? Allowing that option. And even if they act like they're not receptive to it or not listening, they are. And that's part of especially with adolescents, that's part of their attitude and development, is trying to individuate and portray themselves as not needing the help or being able to be independent in these things. But when you do actually listen, it sinks in. It's effective. And I'm having a hard time of trying to just come up with like a scripted example of how to do the empathetic listening. But did that help answer your question?
With the combination of psychotherapy and medication, is there some point where it can become reliant on medication? Because I guess I think about it over time, like how do you know when someone's not depressed anymore? Is it something that you can live with for the rest of your life and you have to do both? Or what about if you're doing both and then all of a sudden you get off the medication and you can't function because for some reason your brain starts kind of relying on the medication? So how do you address those things?
So I didn't go over the recommendation. Typically when you start antidepressants is that from the time that the individual starts to feel better, that they stay on that dose that has made them the therapeutic dose that they're at for at least 6 months to 1 year. And then at that point, working with your provider to talk about if they're feeling better, maybe tapering, decreasing the dose, so that they're just not staying on this medication, lifelong. And most, in terms of, we call them episodes, right? Because usually it's not that they're at that high level of depression for their entire life at that same, height. It's typically that they'll go through an episode of depression, often, in adolescence, maybe again in your late 20s, maybe again postpartum. And so it comes back, not for everyone, but for many, it's, recurrent. There's modifiers that we put on our diagnoses that also say recurrent, episode, because often it will come back. So I think the push is to not leave patients on medications lifelong, but to help them get through the period, the episode, and then taper them off. And then if they need it again, then having them be on the medication again in the future, or if it's milder, maybe just therapy.
And also with that, if somebody is tapering off of medication, weaning down, to be working with a therapist on that, letting them know so that they can address it as well. To start discussing, okay, these are the coping skills that have made you feel better. These are the activities that have helped. You may want to increase these while you're coming off of your medication to address that lack of extra push that the medication gave you. And to know that you may feel these things, and it's not meaning that it's going to be forever or long term. That just means maybe you'd want to revisit staying on the medication a little longer, or trying to push a little harder with the other methodologies of treatment through behavior therapy, talk therapy, and so forth.
Questions?
I have a question on electroconvulsive therapy, and I wanted to know if that's only offered at Queens and how many individuals usually go through this process within a year.
So I am actually not the expert in this field. I wish my colleague, Dr. Carlton, was here. He actually is the main provider here of ECT that I know of. I believe there's another provider on the island that might do that as well at Kahi, but I'm not 100% sure. I don't want to give you the wrong information. And I don't know how many go through it. I did read a statistic just recently where nationally, it's a very low percent, like I think it was something like 0.25%, a very small percent, because it really has to get to the point where it's thought to be treatment resistant, and or they're just not tolerating the medications. And there's so many medications now out there that it would be difficult to say, let's jump to ECT when we haven't tried, these other options, because usually we'll try at least 2 SSRIs before we go to a different category of medication. And there's multiple medications, you can add medications. So there's a lot of different ways, to adjust medications before I would say most psychiatrists will say, let's try ECT because of the side effects that are possible. But Dr. Carlton would know those answers, so if you want to know the specific numbers, I would try to get in touch with him. Yeah, Dr. Barry Carlton.
What if you're showing signs or symptoms, but you're not quite sure if you're depressed or not?
I think the biggest recommendation is if there are signs of the symptoms occurring, to go in and talk to somebody. It can be as simple as going to your family doctor or primary care physician and starting there, or it can be making an appointment with a therapist, and just to get better peace of mind on either side of it. Whether, you're experiencing some things of what people might see as typical depression, or it might be other things. Or, it sounds like you do have depression and we can start to try to address it and work on it. But if there is a question, it should be addressed by a professional. So always encouraging early intervention. And it's the same thing with any condition. Even if it were diabetes, if a doctor sees that somebody could be possibly pre-diabetic, they don't want to say, let's just sit on this and see if it turns into diabetes. They say, maybe you want to start, implementing some diet change, some exercise, just to get ahead of this in case. So even if it's something such as depression, where it may not be fully diagnosable depression, but there are some indications, seeing a provider just to get some input and some direction on how to help in the early stages is always best.
I would also add that, with all the diagnoses, if you look at the criteria, they mention that it's these symptoms plus it causes a significant impairment or change in function. So that can be different for each person, depending on, it's all relative to where your baseline is, right? But if you're seeing that from your baseline, you're experiencing, a major impairment in work, in school, at home, with relationships, something that's a change for you and it's lasting. It's not just one day, it's not just, a few hours, because we all have moments when we're down or experiencing emotions, and that's a normal part of, being human. But this is where it's lasting, 2 weeks or longer, and it's not getting better. That's where you want to consider, is there something more that's going on? And I also wanted to add, one thing I didn't mention in terms of treatment is that in addition to the pharmacotherapy as well as the therapy, there's also other treatments that are over-the-counter alternatives. I didn't go over that, but things that, Forrest had mentioned in terms of preventive treatment. So, exercise, very important. Diet, very important. There are things that are going to boost your serotonin. So like green leafy vegetables, walnuts, salmon, those are all important as well. So being able to look at alternatives, that we just don't look at just medications. We want to see, the whole picture and look at the holistic, picture. So, things over the counter that sometimes, in my practice, there are some families that they're not too keen on, starting the prescribed medications. So sometimes we'll try other alternatives such as 5-HTP. Another one might be St. John's wort. So there's alternatives that are available as well.
Next question. Do you have a question?
I was just wondering, do some of the drugs have a side effect of increasing suicidal thoughts? And if so, how can you tell if it's the drug or the person?
Yeah, so a little bit ago they did have a black box warning for the antidepressants, especially in adolescents and young adults, that there's a less than 1% risk of like worsening suicidal thoughts. And I think there's, some argument or debate about that, because at that point it's difficult to know, is it that you just started the medication and the depression is getting worse, and these medications take a while, to build up. They're not going to work right away. They take like 2 or 3 weeks, the antidepressants specifically. So it's hard to know, I would say, if someone is, getting worse in their depression, and so that's why they're having worsening suicidal thoughts, versus is it really a side effect of the medication. Others have thought that maybe it's a result of activation from the medication. So maybe they're more likely to have more anxiety or agitation from the medication. That might be a possibility. But I think in that percent, it's less than 1%, so that's important to note. It's a very small percent, and it wasn't a risk of increasing suicide attempts, but suicidal thoughts. And so the thought is that someone is going to be, if they're starting on medication, they should be following up, closely with their provider, or with us if they're in partial program, we're seeing them, monitoring them. So if they have any increase, spike in suicidal thoughts, that they would let us know and we would discontinue it or switch the medication.
Any other questions right here?
Let's see. Could you define substance abuse? And is substance abuse alcohol or drugs, or it's both? And how do you differentiate or identify a teenager that drinks alcohol, but is it substance abuse or could it be peer pressure?
Well, clinically and legally, I guess, any teenager that's drinking alcohol is abusing it because it's illegal for them. So it's the same, because it's illicit and they're not of age to enjoy a beer after work or school, then it'd be considered abuse because they are breaking the law to do so. And with that, the specifiers of abuse, use, dependence are a little hazy in the DSM, and the biggest things that they look for within adults and alcohol use, it becoming abuse or dependence, is that it's, again, impacting their functioning. But again, with adolescents, just if they're not using it legally, it's abuse. And that can go for even over-the-counter medications. And that's why there's a big push for checking age and identification with buying cough medicines and other things like that.
And abuse can include anything, whether it's, alcohol, substances, like Forrest was saying, prescribed medications that are not prescribed to them. Maybe they're taking a friend's medications or something they found. That's fairly common, in adolescence. So those are all, we have diagnoses for each of those substances, available that, we would give to a child or adolescent that is abusing those medications. I guess the biggest differentiation then would be between abuse and dependence, where dependence is, where you start to have signs of withdrawal when they're not on the substance, and it's causing a significant impairment in their life, and they're still even when it's, causing problems in their life, they still continue to use it. Those are, some of the main criteria for the differentiation between abuse versus dependence.
Okay, I think we have time for one more question. Go ahead. Oh. Junk in the bowl, no.
Sorry. Hi, thanks. I have a question about TMS. How many treatments does, say, an individual require for it to be effective, and what's the, the space in between for that?
So again, I'm not the expert in TMS. There is a provider. So if you have more questions, one of the providers that does provide it, I know in the community, is Dr. Roberts, Jeremy Roberts. So that's someone to look into, look up and see if you have questions about it. I do know it is pretty frequent. It's like a daily treatment that you have to go to the clinic for every day for, I believe it's 6 weeks, I believe. Maybe 4 to 6 weeks, something like that. And so it would be hard for someone that might not be, able to get to the clinic every day consistently. There has to be that compliance in the treatment. But I think for further questions, maybe look up Dr. Roberts. Yeah.
Thank you.
Mm-hmm.
Okay, one tiny question.
I just wanted to know what your thoughts on using CBD along with therapy and medication.
Well, we get this question a lot, actually. And even with THC, as the medical marijuana is prevalent in the community right now, the biggest concern I have about the CBD and THC is that it's not very well dose controlled. So you're not very clear on how much you're getting of it. Some of the products aren't refined to only containing either the CBD or THC, and it's kind of just out there. There's not the clinical studies that really back it very heavily yet. So I'd have to err on the side of safety and just say, let's see some studies to show the effectiveness and that there's no long-term negative impacts. But I know some people that use it frequently and they have their own pattern of use that they feel is effective and helpful. And I have some people that have used it and said, I don't ever want to try that again. So it kind of differs. And again, just from my professional standpoint, I'd say to have to wait to see the studies and have some dose control.
All right, wonderful questions, everybody. How about another round of applause for Dr. Angela King and Forrest Wells? Thank you. Okay, I'm going to tell you the exciting subject of next month's Speaking of Health lecture in just a moment, but first want to say mahalo to Val Milstein and Patty Sakal, who worked so hard providing our sign language interpretation tonight. Also, yay! Also, thank you to the Queens Medical Center's Behavioral Health Department, as well as the Hawaii State Department of Health's Child and Adolescent Mental Health Division, who were in the lobby earlier this evening, providing great information to all of you. And mahalo to our Queens volunteers, Jen and Sophia. All right, our next Speaking of Health lecture here at Punch Bowl is titled Advances in Hip and Knee Replacement Surgery. Do you have chronic pain in your hip and knees? Are you thinking about surgery as an option? Recently, advances in research and technology are resulting in a more successful outcome for many people. Dr. Thomas Kane, an orthopedic surgeon, will talk about enhanced recovery and why Queens is proving to be the best option for many patients. That's Wednesday, February 26th. It's going to be early again, 5:30 to 7 o'clock, because I believe he's going to be bringing a patient with him. And it is free here at the Queens Conference Center. You can register online at www.queens.org, click on Classes and Events, or call the Queens Referral Line at 691-7117. Thank you for attending the Queens Medical Center Speaking of Health lecture. Don't forget to get your parking validated in the lobby and drive home safely. Good night.